From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Hi, this is Dr. Clyde Yancy, Deputy Editor, JAMA Cardiology, Professor of Medicine and Chief of Cardiology at Northwestern University Feinberg School of Medicine in Chicago. I am delighted to host today's JAMA Cardiology podcast, a podcast that features not only one of our authors in JAMA Cardiology, but also one of our associate editors, Dr. Ajay Kirtane from Columbia University in New York. Our goal today is to discuss hypertension and to really focus on the potential benefit and some of the questions about renal denervation as adjunctive therapy in the management of patients with high blood pressure. Welcome to our podcast.
Well, thanks so much for having me on. It'll be fun.
It will be fun. We're talking about hypertension, Ajay, and just to level set everyone, we recognize this is the leading cardiovascular condition worldwide. That bears repeating. This is the number one cardiovascular condition worldwide, and certainly the consequences are well known. Myocardial infarction, heart attacks, stroke, kidney disease. This really is an important condition that has significant consequences. And we understand the public health burden, particularly in certain underrepresented communities. So there is an imperative for us to understand how best to treat this condition. Fortunately, we have clinical practice guidelines that are informed by an extraordinary evidence base acquired over decades that now help us understand clearly how best to modify the natural history of the condition. But as we know, we are oftentimes unable to fully control blood pressure, whether it's because of the exigencies of taking the medicines and adopting the lifestyle, or that we just don't have all the tools necessary. One of the most exciting things about this whole space, Ajay, is that we continue to see true breakthrough developments, whether we're talking aldosterone synthase now with new drug therapies, whether we're thinking about new technologies that allow us to measure blood pressures better, record blood pressures better, communicate with our patients better. This really is a space where significant innovation is occurring, and that has not been absent the innovation in the device-based therapeutic sphere, which is where you own significant expertise. This whole conversation then is about how does a device-based therapy interdigitate with lifestyle and medical therapies as we know them for high blood pressure. So Ajay, let's begin by reviewing where have we been with this whole phenomenon of device-based therapy as an adjunctive therapy for hypertension.
I think you set the stage really well by zooming out in the sense that the problem that hypertension is around the world, it's actually kind of remarkable. I actually find it a little bit sad that it's the number one public health target if you want to really affect a lot of people's lives. And yet when it comes to the management of hypertension, we just do a really bad job. I think people think they know how to manage hypertension. Drugs are generic. Lifestyle modification is frankly free many times, and yet there's so many people who still remain uncontrolled. So it's kind of within that backdrop where the space of hypertension-based device therapeutics has a niche in the sense that it's a way that we could treat blood pressure that's somewhat independent but synergistic with all of those other things, lifestyle modification and medications. So my feeling is that there was a lot of hope and promise when these technologies first started getting investigated over a decade ago, that we could maybe short circuit that whole paradigm and obviate the need for medications and maybe not have to worry about lifestyle and maybe just treat people with devices. And I think what's been pretty clear with the studies that have been done to date is that's obviously not the case. These always have to be adjuncts. As a proceduralist, one of the first things that I always think of is, does the patient really need the procedure? And if there are things I can do to have the patient avoid having a procedure, that's obviously better for them. But in the cases where the procedure could help, that's the patients I focus on when considering procedures. So that's how I like to think about it. Specifically with regards to renal denervation, this is a concept that's been revived based on a surgical paradigm in the 1950s before antihypertensives even existed. And the idea here was to kind of emulate that sympathetic downregulation with a device that could approachably target the renal nerves, which we all know are central to the pathogenesis of hypertension.
And now let's really take a deeper dive. We know the problem is hypertension. We know the shortcomings in our efforts to treat hypertension. And you've given us a crystallized summary of the development of this technology. Tell us first, what is renal denervation? Because there's been more than one way to get to that.
Absolutely. And for the time being, this remains an invasively applied therapy in the sense that there were some investigations trying to see if you could denervate the nerves externally, ultrasound, for instance, but all the trials that have been done to date successfully look at a variety of energy sources, whether it's radiofrequency ablation, whether it's ultrasound, or even ethanol ablation, and they target the nerves invasively. So what it takes is a procedure where you get arterial access, you navigate your way to the renal arteries, and because of the co-localization of the renal nerves surrounding the arteries, you can then essentially apply any ablative therapy to interrupt nerve signaling, both afferent and efferent, from the central plexuses out to the kidney and back and forth.
We remember, though, in version 1.0, this really clever technology seemingly was imperfect because we were able to look at pathologic specimens, and we saw that the radiofrequency ablation in particular was not truly circumferential. It was almost hit and miss. And as a consequence, we didn't see ultimately the kind of control we wish, correct?
That's absolutely right. I think in some patients, the control was there. In other patients, it wasn't. And the variability was in part due to the fact that these were incomplete ablations. The preclinical data showed us that more effectively. And because radiofrequency ablation essentially creates a wedge-shaped ablation over a very limited length, we were also at the time focusing our ablations more proximally near the ostia of the arteries where the nerves are farther away. And so we weren't always reaching the nerves. It was a random effect of sorts. And so over time, there's been iteration to the technologies such that we're trying to achieve more circumferential ablations. We're trying to achieve ablations more distally in the arteries where there's more convergence of the nerves closer to the arteries. And that appears to have led to a more consistent effect when we apply these therapies.
So this really becomes a brilliant discussion because there are at least three ongoing pathways. One, trying to identify the clinical circumstance in which this is the right application. Is this, for example, instead of medical therapy, in addition to medical therapy as an adjunct, or is it necessary and appropriate most when there is lack of control even after multiple medical therapies? Or is this a story of technology development, for example, going from radiofrequency to ultrasound? Or is this a story, as you've just expertly identified, of understanding how to do the procedure? It seems relatively straightforward to cannulate an artery, but then what do you do? And so let's fast forward to where we are today. We have the ultrasound platform, seemingly the one that is extant today, and we have a host of clinical trial data coming to fruition at the same time. Give us a summary of the clinical trial data that is contemporary, addressing the use of ultrasound renal denervation.
This is germane to the article that we published in JAMA Cardiology, where we pooled 3 sham-controlled randomized trials of ultrasound-based therapy versus a sham. And the reason we did those studies was to achieve proof of concept. So 2 of the 3 studies took patients off of medications. They were either uncontrolled at baseline on medications. In some cases, they were just uncontrolled, having had tried medicines in the past, and they were randomly assigned to denervation versus sham. These patients had to have blood pressures that were elevated, on average approximately 150 millimeters of mercury systolic, when they were taken off medicines, and then they were randomly assigned to the one therapy versus the sham and then followed for 2 months. But we took those 2 studies and pooled them with another independently powered sham-controlled trial where patients were actually somewhat resistant. They were on 3 medications at baseline, in fact, through combination therapy, a calcium channel blocker, thiazide diuretic, and an ARB, and still had blood pressures in the 150 range. And similarly, they were randomly assigned to denervation versus sham. Now, we've published each of those 3 trials separately, but for the purposes of this analysis, we thought that we would help combine them together in a patient-level, patient-based way to then determine if there was consistency of effect of denervation versus sham. And what we showed at 2 months of follow-up, which is the primary endpoint ascertainment for all 3 trials, was that there was a reduction with denervation that was greater than that of sham. There was a minimal change from baseline in the sham group. Obviously, we don't think that a placebo procedure is going to have much of an effect on blood pressure, but that was largely because we controlled medications so assiduously through the trial design. And when you compared one group to the other, there was a reduction. Now, I'll point out, and this is super important when we get back to your point 1 and point 2 about what patients we're going to be applying this in, is that the overall reduction in blood pressure is not like we might have seen in the early days of denervation, where people were showing reductions of 30 millimeters of mercury, and there were hopes that you wouldn't have to take medications anymore. In fact, you need to do trial designs this stringently in order to show an effect. What that means to the layperson, whenever you have to so carefully control medications, you know that the reason you're controlling them is because the overall signal is a more modest signal. It's not a dramatic signal. And therefore, if you don't control items like the medication burden in each group, you're going to lose the signal in noise. And so the realistic way of looking at these data is, while they're certainly encouraging, there was consistency across all patient populations in terms of the reductions that we saw. The reduction was approximately 8 millimeters of mercury, and that was consistent across daytime ambulatory, home, and office measurements. The comparison to sham, it was approximately 6 millimeters of mercury, but from baseline, it was about 8 to 10. So that's the reduction. It's consistent, but let's make sure that we're doing everything else right first, whether that's medication adjustments, lifestyle modification, because this is only going to be an incremental therapy synergistic with those other changes.
So this is really where we can begin to put this in context for the listener and for the clinician. We have another tool to help support the management of patients with hypertension. We can look at the benefit now in a very realistic way. It is probably on the magnitude of an additional 6 millimeters of blood pressure reduction. We shouldn't think that's trivial, though, because we know from a public health perspective, even a delta of 3 millimeters of mercury at the population level is definitely associated with a reduction in the risk of stroke. We don't have those kinds of outcomes data specifically for ultrasound denervation, but we do know in general that there are favorable outcomes that track with modest to moderate reductions in blood pressure. And so now we get to the threshold of what this all means. From my perspective, what this means is that we start first. I want to be very clear. We start first with lifestyle. We emphasize the importance of non-pharmacologic therapies, particularly diet, activity. We emphasize the importance of refraining from tobacco, reducing alcohol consumption, increasing potassium consumption, diminishing or eliminating sodium consumption. We cannot get away from foundational steps that can help us use lifestyle to manage hypertension. With medical therapies, we have the benefit of inexpensive medicines available generically. We know that the thiazide diuretic, regardless of the iteration now, is an appropriate choice. And we know that for many patients, if we have to go beyond a thiazide plus a RAS blocker or a CCB, that an MRA is an excellent choice to effectuate better control. But now we realize that there's yet another tool, pending more research in other directions, but there's yet another tool that can help us control blood pressure. Ajay, this has really been a great call. Let's go ahead and wrap up. Let me give you the first shot at a closing statement.
Well, first, I just want to say I couldn't agree more with the statements you made. I would also point out for the practitioners out there that while we think that we may know a lot about treatment of hypertension, there's always more to learn. And when I got involved in this space, I didn't really know very much about combination therapy. And what I mean by combination therapy is starting patients on two medicines at the same time, combined in the same pill. When, for instance, I did my residency, that was something we tried to avoid because that was something that, for instance, the reps wanted to make us prescribe. And we said, well, we could just prescribe the same medicines generically, single. It actually turns out now those combinations are generic and they are more effective if you do it in one pill than the exact same medicines in two separate pills. So combination therapy works. It's important. Refresh yourself on the guidelines. Refresh yourself on secondary causes of hypertension that need to be worked up. And then look forward for this therapy to be approved in the coming year. But again, exercise judgment. It's a procedure. Patients sometimes benefit from procedures, but pick the right patients for the right procedure. And I think that's the best way to proceed.
Yeah, Ajay, I love the fact that you acknowledge Those of us that have been in the hypertension space for a while probably invented implementation science, trying to find a straightforward, efficient way to treat people for a chronic condition for which there's minimal symptoms until it's almost too late. I'd just like to close with one other point. I think ultimately the real solution here is primordial prevention, starting very early in life and avoiding the actual onset of high blood pressure. It can be done by thinking about health and nutrition, physical activity. These are messages that are quite salient and really reflect strategies we should better deploy as we go forward. This has been Clyde Yancy hosting JAMA Cardiology podcasts featuring one of our authors and in particular one of our associate editors, Ajay Kirtane from Colombia. This has been a wonderful conversation about hypertension broadly speaking, but uniquely focusing on renal denervation therapies. Stay tuned for more podcasts from JAMA Cardiology. We will continue to bring you fresh content and share with you topical issues from the pages of JAMA Cardiology. Thank you very much. This episode was produced by Shelley Steffens at the JAMA Network. The audio team here also includes Daniel Morrow, Lisa Harden, Audrey Foreman, and Marilyn Furkaluk. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.